Hello, thank you for inviting me to present today. My name is Helen Walker. I'm a sports and exercise physiotherapist working in Melbourne, Victoria, the state of Victoria. The presentation today is drawn from my experience as a private practice physio. I work across some high-performance sports as a consultant, working closely with the Victorian Institute of Sport network. I also work a little bit in professional sports. The high-performance sports I'm involved in include swimming, so Swimming Australia High Performance Program, the Malaysian track cycling team at their Melbourne base, and also with horse racing with the Racing Victoria Apprentice Jockey Program. And the title of the presentation today is Physiotherapy and High Performance Sport During the COVID-19 Pandemic. So just an outline of my presentation. Today I'll be talking about the COVID-19 pandemic timeline in Melbourne, just to give you a background as to why physiotherapy servicing has changed in high performance sport and private practice. I'll talk a little bit about the high performance sport response, the specific changes to physiotherapy provision in Melbourne, and it's been a challenging year for everyone across the world, and with specific challenges here in Melbourne, Victoria. So essentially the COVID-19 pandemic timeline this year has been divided really into the first and second wave in Melbourne and the state of Victoria. The first wave really started around the end of March through to early June. The number of COVID-19 cases peaked at approximately 111 cases in a single day. In speaking to this today, I'm speaking as a physiotherapist in private practice, not in representation of the Government Department of Health. So the Victorian Government, in response to the first wave, put in place stage 3 restrictions, which colloquially we refer to as the lockdown. There were stay-at-home orders where the general public were able to leave home for the following reasons, including for permitted work in essential industries, to seek medical care, for shopping for essential items, and to exercise every day. In the first wave, high-performance sports training venues were closed, and the professional sports such as the football codes, netball, basketball, operated in COVID bubbles. So my understanding is that each professional sporting body liaised on an individual basis with the Victorian Government to develop their approach to a COVID bubble, and these measures included things such as limiting the number of participants, regular COVID testing of athletes, staff, and in some cases isolating players, staff and the families from the general population. But that was worked out on a sporting code basis individually with the government. Then we were fortunate in June this year to have a temporary period of opening up for a few weeks where the Victorian Government moved to stage 2 restrictions. During this time, telehealth physio, whilst being the preferred mode of service delivery, was also supplemented by the resumption of in-clinic consults with COVID protocols in place. When we went to stage 2 restrictions here in Melbourne, the high-performance sport training venues opened with a COVID plan, and I'll speak to that a little bit later, and they have remained open to this day. Unfortunately, in Melbourne particularly and regional Victoria, we experienced a second wave starting in early July. During this second wave, COVID cases in the state of Victoria peaked at over 700 per day, and to date there have been a cumulative caseload of over 20,000 people affected or diagnosed positive with COVID-19 in Victoria, and to date over 800 deaths. In response to the second wave, the Victorian government reinstated firstly the stage 3 restrictions, and because the case loads kept increasing on a daily basis, the government then progressed through to stage 4 lockdown. During stage 4 restrictions, which we are operating under at the moment to a certain extent, the government's definition of essential industries was tightened up, so fewer people were able to work. A curfew was implemented from 8 p.m. to 5 a.m. People were able to leave the house once a day for 1 hour only. Movement control orders not being able to travel beyond 5 kilometres, 1 person a week allowed to shop for groceries, all retail closed, etc. During this period, professional sporting codes moved interstate within Australia, where society was much more open, and they have been able to undergo their competitions. In the second wave, telehealth physio again has been prominent, and further restrictions on physio service delivery were commenced, being for urgent care only, and certainly it was very much emphasised that no routine care was permitted at all, and I'll speak to that a little bit more shortly. In the high-performance sport setting, during the first wave, all of the training venues in Victoria were shut. So depending on which sport an athlete participates in, that really determined what effect it had on their ability to maintain their training loads. So, for example, with swimming, all of the swimming pools were closed, so swimmers underwent cross-training. However, in the context of cycling, there was access, of course, to road cycling and ergo sessions, but no access to the velodrome. So coaches delivered their training programs remotely. Gym equipment was provided to the athletes, including weight racks and cardio equipment. Towards the end of the first wave, the Victorian Institute of Sport started monitoring athletes remotely through the Athlete Management System, or AMS, for COVID symptoms. So they were preparing to set up the criteria that athletes must be 14-day COVID-19 symptom-free before they're allowed to train, and they must have logged that status in the Athlete Management System. The Victorian Institute of Sport gym and treatment facilities reopened temporarily in June in that interim period between the first and second wave. With the second wave, obviously caseloads of COVID were much higher. The Victorian Institute of Sport again closed for all activities except for the restricted medical services. However, the high performance sport training venues remained open under what we call the Victorian Government's High Performance Sport Exemption Program, and that applies to athletes who are competing at both national and international levels. So you really need to be high performing to have access to your usual training venue at this point. In terms of physiotherapy servicing during the pandemic, the first comment I'd like to say is that physiotherapists in Australia, I'm not sure of the status in Malaysia, but here in Australia, we are primary contact health professionals, which means a member of the public can book in without a referral from a medical professional. So in terms of whether to see a patient face-to-face or not, the decisions have been made by the treating physiotherapists on a case-by-case basis. During the first wave, we shifted to telehealth only in line with the BIS recommendations. As noted on the slide here, high performance sport was operating as a train at home status, so therefore there was less need for maintenance treatment during this first wave. Under the stage 3 lockdowns during the first wave, urgent care only could be provided in the clinic. Non-essential manual therapy was avoided. Hands-on treatment was provided as a last resort only. So within the context of high performance sport, however, even though we were not doing any face-to-face consults during the first wave, we did telehealth injury triage as required. Fortunately, in my practice, there weren't any urgent injuries to deal with. As a minimum, athletes were contacted and underwent a telehealth physiotherapy session every week, during which time we would run through self-management strategies and particular exercises. For squads of athletes, we delivered group exercise sessions, usually using Zoom as the technology. In particular sports, such as swimming, we developed preventive programs because we knew that without the swimming pools being open, that athletes were really subject to significant training deload in terms of their shoulders, and we know that swimming shoulder injuries are very high risk. So we certainly put in place dry land preventive programs for these athletes to try and minimise injuries on their return to training. The other thing that we focused on during this particular phase was what we termed the 1%ers. So athletes, because they weren't doing their track training or swimming pool training, they were able to really focus on the things such as flexibility that may be a long-term work on, and we were really able to target our interventions to work on those small percenters that athletes usually they're quite time poor, and they're unable to work on everything all at once. So it was certainly an opportunity to try and get some good change in areas such as flexibility or movement control or skills. During the first wave, as I mentioned before, the remote monitoring for COVID symptoms commenced, so that everything was in place for when the training venues reopened. Now, physiotherapy during the second wave was again heavily impacted, and in this particular situation, physiotherapy remained an essential service. However, a number of industries in Melbourne have been and still are shut down. The government in this instance and AHPRA, the Australian Health Practitioners Regulatory Authority, provided some very detailed criteria for face-to-face physiotherapy sessions. So at first, we needed to do telehealth first. No routine care was permitted. In-clinic treatment was allowed only to prevent a significant change or deterioration in functional independence, necessitating an escalation of care. So in this instance, the definition was very tight, where the escalation of care meant that a patient may need input from a medical specialist, and when you were trying to avoid a hospital admission or an emergency department presentation. At the moment, because the current cases in Melbourne are down to roughly 10 or so per day, restrictions have eased off somewhat, and we are able to see people to prevent a significant deterioration, such as the need for increased treatment frequency to prevent a significant increase in pain or increase in recovery time. We can also see patients whose care was delayed during the stage 4 lockdown, and work with people who are undergoing essential pre- and post-operative care. So in preparation for returning to, hopefully in the not too distant future, a COVID normal here in Melbourne, Victoria, the Victorian Institute of Sport has developed some guiding principles. This was actually in place in June when we opened up temporarily, and some guiding principles for face-to-face consultations and hands-on manual therapy to help us decide whether face-to-face treatment is indicated. So COVID normal is looking like telehealth will be the preferred service, and then face-to-face only when indicated. So we are asking ourselves the following questions. Have I exhausted all other methods in my treatment options in a non-hands-on consult? Is the patient's conditioning worsening? If so, does evidence-based medicine suggest a hands-on technique will improve outcomes? Has the patient's condition plateaued? Would manual therapy or hands-on treatment assist patients to move beyond this plateau or hurdle? Then considering whether a return to hands-on treatment increase the expectation of routine hands-on consults, when really we do still want to be minimising infection risk by using telehealth as the primary modality. How will we manage athletes and patients' expectations of routine care being reinstated? And when someone does come into the clinic, are we going to do a hands-off treatment session where we're more closely monitoring in real time or face-to-face their exercises whilst maintaining a 1.5 metre social distance, or are we going to do a hands-on treatment? And finally, we're really trying to weigh up, will a face-to-face consult improve the outcome? What is the risk versus the benefit for the athlete, the sport and the community? The other thing we have in place is every physiotherapy business or setup in Victoria has what we call a COVID safe plan, the basics of which are infection control, so regular cleaning of frequently touched surfaces, your doorknobs, desktops, exercising equipment with hospital grade products, keeping a cleaning audit, using disposable paper products on the treatment tables and the face holes, not using linen, no pillows on the treatment tables. Hand hygiene is paramount. Sanitising regularly on arrival, patients sanitising their hands after they touch any equipment. Hand washing, pre-screening patients for symptoms and recording that, temperature check on arrival, using the appropriate personal protective equipment or PPE. It's compulsory for physiotherapists in Victoria to wear a mask and a face shield, compulsory for patients to wear a surgical mask, trying to observe as much as possible the social distancing rules. So within a premises, we're not allowed to have more than one person per 4 square metres, and we to try to maintain a 1.5 metre distancing wherever possible. Obviously that is very difficult when you're doing manual therapy, so we try to limit the amount of manual therapy delivered during a treatment session. We use floor markings on the floor in reception and spread out the reception chairs to promote social distancing. The movement of staff is limited, so wherever possible people can only work at one location, essential staff only present, and other strategies such as logging all attendees to a premises so that in the event of a positive case that contact tracing is facilitated. Lots of signage to promote COVID-safe behaviour, such as the hand hygiene, the masks, the social distancing, and having a response plan for positive cases. So this is a government requirement for all businesses, in fact, in Melbourne. So because telehealth has been a mainstay of physiotherapy service delivery, I thought it'd be helpful to discuss what we think are both the pros and cons of this mode of service delivery. So firstly, in terms of the accessibility, obviously you need to have an internet connection and device, so that may limit the number of people that you can work with if they don't have that technology available. That being said, there has been an increase in uptake for athletes and professional sports people in regional areas where they may not have a physiotherapist in their local town. So that has been a definite advantage of the emphasis on telehealth this year. We find that delivering exercise therapy is excellent and possibly not too much different to an in-clinic consultation in terms of how you can monitor the person's skills. Now, many of our physiotherapy skills that we use require basically no touching of the athlete. So things such as a good subjective examination using your clinical reasoning. You're still able with telehealth to develop a rapport and buy-in with the treatment program. A particular advantage during this time when people have been locked down and under curfew is we've been able to maintain some continuity of care and have been able to monitor the athletes and the patients for deterioration in symptoms. Telehealth is actually quite good for delivery of group exercise such as floor work, Pilates, activation before training. So we have been able to use that technology to run through the stretching post-training and the activation prior to training with athlete groups. You're also able to assist the patient or the athlete to deliver self-treatment, so using foam rollers, massage balls, some of the Mulligan, I'm not sure if you're familiar with that particular form of treatment, but self-mobilization techniques with movement, and we can supervise that. So you can successfully treat an acute wry neck with some of these movement techniques. The other positive about telehealth, it really empowers the patient, helps them be less reliant on passive treatments we do to them. I noted before that it can help the athletes really focus on working on the small things that they need to do to improve their performance. And it overall requires an athlete and a patient to be a more active participant in their treatment program. There's also some good emerging evidence around the efficacy of telehealth physio, and here KarenFinnan.com has a good, she keeps a good list of research articles about telehealth in physiotherapy if you want to have a look at that. So of course the cons. Telehealth physio, we recognise absolutely it's not the same as a face-to-face consultation. There could be privacy concerns, so it's most important to choose the delivery platform very well, ensuring we've got end-to-end encryption. A lot of practice management software programs have a telehealth facility now, so strongly suggest you look into the privacy aspect. Of course, there can be some poor stability of the internet connection which can negatively impact your session. We have made sure that we seek specific consent to do the telehealth physiotherapy consult, so making sure we explain to patient it's not the same as a face-to-face consult. There may be some issues with technology, with the internet connection. We may have to reschedule an appointment, and also we may need to progress to face-to-face assessment to ensure the correct diagnosis. Often a full objective examination may not be possible. Things such as special tests, for example, a Lockman test at the knee, cannot be delivered over telehealth. You can't do dynamometry strength testing. We do get patients to self-palpate to help guide diagnosis. However, this may not be as accurate. Well, obviously is not as accurate as a clinician palpating the tender musculoskeletal structures. Furthermore, there might be a lower threshold for imaging. So in terms of facilitating diagnosis, with telehealth, we tend to move forward to imaging perhaps a bit earlier than we would with a face-to-face consultation. One of the big disadvantages is patient expectations not being met. Certainly there's been a number of athletes and patients who want hands-on treatment, and we've needed to work through that with them given the circumstances of the public health restrictions and the public health problem. Physiotherapist expectations as well of a treatment session may not be met. Certainly to deliver predominantly telehealth physio requires a change in mindset. Physios have had to overcome their resistance to change. We need to recognise it's not the same as a face-to-face consultation, but certainly a lot can be achieved, and it's important to try and make the most out of the situation. There's also a different physio skill set is required. There's a heavy reliance on verbal cues. You're unable to provide physical feedback about an athlete's position, say, for example, during a squat. So you really have to explain yourself very well, and certainly that verbal feedback and developing those skills is and has been really important. And because of these nuances of a telehealth physiotherapy consultation, it's certainly a more time-consuming process than a face-to-face consultation. So that being said, we've worked out a number of ways, I think, of maximising the efficacy of telehealth physiotherapy. So firstly, sending patients a how to prepare for your telehealth consult information sheet, such as having a dedicated space, having a camera set up well, no interruptions, having available exercise equipment. It's really important, rather than the physio just sitting down at their desk, to get up and demonstrate the movements just as you would in a physiotherapy face-to-face session. That's very important. Get up, move around, show the patients that you're actively involved in the session. Important also after each intervention, because we are relying on exercise therapy or self-management techniques, to retest the painful movements after the intervention to see if we're getting the change that we desire, and also that helps with patient buy-in. Very important with a telehealth session, because you're not getting those usual subtle cues that you can observe in face-to-face consultation. So it's really important to avoid awkward silences, provide ongoing feedback during the session. Patients have asked to record the session so they can watch it back and repeat the learning. So that's been quite helpful. Also, the use of exercise software is very helpful. We use PhysiTrack so that exercises are prescribed, they run through during the telehealth session and then delivered to them remotely on their device for them to follow. you can make sure you utilise the share screen function. So in that you can share images of anatomy to help educate the patient about their injury or diagnosis. You can put up a visual analogue scale to rate the patient's pain. One way we have worked to monitor strength is at X number of reps with a certain weight, asking the patient for their Borg's RPE, their rating of perceived effort or exertion, just to get a guideline for how they're progressing along. And the use of patient-reported outcome measures has become increasingly important just to track their progress. So 2020 certainly has been a year full of a number of challenges within the context of physio and high performance sport. We've needed to adjust to changing restrictions in what we're able to do, opening and closing of training venues and different directives around what type of patients and what type of conditions, I should say, like urgent care only versus being able now to see people whose care have been delayed. So it's been challenging to adapt to all of the restrictions. Certainly one of the challenges is delaying care and whether that has increased the injury risk. Another challenge has been managing both coach and athlete expectations. So what we have found through the second lockdown is that the training venues have been open, training continues, and along with that has come the expectation of business as usual in terms of business as usual with physiotherapy care, and because of the Department of Health restrictions we have not been able to deliver the usual care. That is certainly challenging to manage those expectations. So some things are perhaps dealing with a perception of underservicing, or that the athletes may be at increased injury risk if they're not having their regular soft tissue work done. And then furthermore, another challenge has been when injuries have popped up and we've treated them and then going back to telehealth, we've had to work through with the athletes around their expectations of ongoing maintenance treatment. One of the key points, though, that has been helpful within this setting where we have not been able to deliver our usual care is that we really need to make sure we educate both athlete and coach alike that good training load management is better than passive therapies every single time for injury prevention. So really emphasising that we're not getting those fluctuations or spikes in training load, and that is the key factor for injury prevention. The other thing that we've also spoken about is once again the empowerment of athletes around their self-management. So certainly when they travel and they're not travelling with their treating staff, physiotherapists, or massage therapists, then they certainly, this period has shown them that they're really able to do a lot of this management of their range of motion and their soft tissue status or tension, soft tissue tension. They're able to manage that quite effectively with stretching and self-managed massage techniques. So finally, I'd like to thank you once again for this opportunity to present. I work at physiotherapy.com, and this is my email, helen@physiotherapy.com. Thank you.